My name is Dr. Tyler Tolbert.
And I'm Dr. Soren Paape.
And you're listening to the Fix Podcast,
your source for all things implant dentistry.
Hello, and welcome back to the Fix Podcast. We have our second guest episode here, and it is a heavy hitter. I am really hoping that this episode is going to showcase all the things that we're trying to do here with the Fix Podcast and adding this visual element, because what we're about to be going over is something that would absolutely not be serviceable on an audio only format, because you got to be able to see this stuff to really understand what's being talked about. We're going to get really nitty gritty and get into some finer details that I'm sure will humble Soren and I as well. So fortunately, we have a very knowledgeable and very experienced, you probably already know who he is, Dr. Samy here, and he's going to be telling us all about the PATZI Protocol, the ins and outs of it, the applications in highly advanced cases. So we're super, super fortunate to have him here, and he's going to have some slides for us as well. And I think this is going to be one of our most educational episodes ever. So super excited to have you on, Dr. Samy. Thanks so much for coming.
Hey, thanks guys for having me on. And man, you're definitely set the bar pretty high, so we're gonna have to deliver. But yeah, no, it's great what you guys are doing. I think incorporating a visual component is really important when we're talking about these kinds of concepts.
For sure. So
absolutely. I think this is a great episode coming off of Clark Damon's. We just had Clark Damon on, Sammy. We went from beginner to remote anchorage. And we just kind of dabbled a little bit in PATZI Protocol, like talking about some of the like where people should be at before they start trying out these types of implants. So I think for the audience, if you guys want like a little more approachable episode, start with that one, and then once we're through, then we can you can jump into this one.
For sure, absolutely. So, just for everybody at home that for whatever reason is somehow unfamiliar with Dr. Samy, if you wouldn't mind, just kind of give us a little bit of a background. Who you are, what's your training like, where are you at. Dr. Samy is actually 6 months into a startup, which is really cool. We can certainly talk about that a little bit, and then we'll kind of bridge into talking about what PATZI is and where it came from.
Yeah, so I'm Samy. My full name is actually Shovik Panasamy, and I just kind of adopted Dr. Samy, kind of then transitioned to Dr. Samy. So I'm from Chicago originally, so all my training was done in Chicago, University of Illinois, and I stayed there for oral surgery. So I finished up, in 2020, right in the middle of COVID, and I did a little bit of associateship, almost 2 years of a private practice associateship there. I'm super passionate about full arch and doing just really like kind of transformative cases as much as I can. Had a little hand in academia a little bit. And then I moved to Austin at the very kind of end of 2021. And what I did is I started to do some kind of full arch, like part-time full arch and then part-time traditional oral surgery. And during that time, I was kind of prepping for getting my startup going, which is Neva Dental Specialists. And Tyler, like you mentioned, we've hit the six month mark. So it's crazy how far how fast that time has gone by. But it's a lot of fun, and that's like a separate episode. We can talk another time about that. Fair enough. But
yeah, no, that's awesome. So. Clearly you have a lot of experience in full arch. People are starting to see your face everywhere. Starting to see the PATZI Protocol, being talked about in full arch conferences all over the world. And I think that, when we start to get into this, what really the essence of it is that, it's a formula, and it's a venture into what's going on to the mind of a full arch surgeon as they try to work through a case. And personally, and we'll kind of get into this a little bit later, I believe that even if you're not the most advanced full arch surgeon, even if you're just trying to wade into the waters, understanding concepts like this, understanding how that brain works is super important. And it's something you can start from the very beginning. And as you add on techniques and get that sort of comfortability with more advanced or revision type cases, that PATZI protocol, you'll start kind of adding letters to what you're able to do. So can we talk a little bit about, how PATZI came about? What was it born from? Why is it named this? Let's kind of dissect it a little bit, if you don't mind.
Yeah, absolutely. So what we can do is we can kind of just jump in or double click on that kind of journey from Chicago to Austin. Really the main reason why I kind of made that move was to get the practice started, but also to have the opportunity to work with Dr. Holtzclaw, Dr. Dan Holtzclaw, and Dr. Juan Gonzalez. And they had a small practice out here, kind of north of Austin, in this town called Round Rock, and basically a full arch center that Dr. Holtzclaw had started many years back. And at that time, we're talking 5 years plus. It was very unique because Dr. Holtzclaw had already been placing pterygoid implants for many years, kind of from incorporating pterygoid implants into full arch. And he published a paper about the pterygoid fixated arch stabilizing technique, the FAST. I make the same mistake of pronouncing it PFAST. Yeah,
I've said PFAS all this time. It's fast.
Yeah, it's fast.
Doesn't Holtzclaw get frustrated? Yeah.
Yeah, he's like, it's so obvious. But I called it PFAS for a long time until I heard him say it. But that was kind of the first time, like the world had seen, like, oh man, if you put pterygoids on a full arch case, there's no cantilever, and there's high composite torque value, and we can get these beautiful full arch prostheses, without having a shortened dental arch in the case of those really severe anteriorly pneumatized sinuses. So he was already doing that. And then when Dr. Gonzalez joined him, he was already well versed in zygomatic implants. So they had this kind of nice interplay there where the story goes that Dr. Holtzclaw taught Dr. Gonzalez zygomatic pterygoid implants, and then vice versa, Dr. Gonzalez taught Dr. Holtzclaw zygomatic implants. And that kind of put them in this really unique position. Remember, this is like a while back. This is like 5 years plus. And they were kind of the only center in the area that had the ability to really do both. And that kind of enabled just extreme versatility in handling the really tougher cases, really atrophic cases. And that's what attracted me. So the reason why, what I think, and you can ask him, but the main reason I think why they were okay with me joining or why they selected me was because I had some experience with zygomatic implants, and I had just published my paper on the zygomatic implant. Basically, it's like a restorative protocol for zygomatic implants. A razor, correct? Yeah. And I joined Juan and Dan, and we're seeing these cases. And I like to think my brain is very algorithmic. I like to kind of systemize things, and I'm also learning at the same. I'm learning from these guys, and I'm just trying to think, well, what would I do in that situation? Or what if I don't get the pterygoids here? What would I do? And a big part of that razor protocol was building off of Bedrosian's kind of algorithm from that, the zone 1, zone 2, zone 3. And then he kind of goes through, if you have bone only in zone 1, you do this. If you have 1, 2, 3, you do this. So what I wanted to do is I thought, it'd be really cool to incorporate a algorithm protocol for full arch that can incorporate zygomatic implants and pterygoid implants and any remote anchorage that there is. And I started watching the way, this is when I was mainly with Juan, I started watching the way he'd do cases. He would always start with the pterygoids, and then he would go to the anterior, and he would always say, hey, that way, you're really establishing your posterior and your anterior stops. And then the variability here is going to be where your sinus is pneumatized. How anteriorly pneumatized is it? How is it not? And then he would do the tilted or the middle ones last. And I was just watching him do these fast cases. I'm like, man, this is really cool. But every now and then, either he wouldn't get a pterygoid. Don't let him hear you that I said that. Or he would.
He's batting 1,000.
The tilted
That's
implants. The tilted implants would end up being so anterior because of how pneumatized the sinuses are that your arch length would be super short, like first premolar, or even like some of these really severe cases, it's like the distal of the canine almost. So even with one tooth cantilever, it's not a very aesthetic arch, and it's not as functional as we'd like it to be. So what he would do is he would say, okay, if I can't get, anchorage back further than the first premolar, second premolar, and I don't get a pterygoid, I'm going to do a zygomatic implant. So between all of kind of like learnings and kind of my own interests as far as trying to systematize this thing, what I was doing, I was looking at how can we create an algorithm that incorporates all of this knowledge and have it in a systematized fashion. So that's really how it came about. And then the three of us kind of put our heads together and put out the paper. So What we can do is let me actually just share my screen here because I'll show you kind of an example of
Sure.
a great example of like why it is important to have something like PATZI.
Hey, Dr. Samy, can I ask
Okay.
you a quick question before you jump into
Yeah.
this? Um,
hmm
when you were in your oral surgery residency, did they do any sort of remote anchorage style implants? Did they allow you to place any of those while you were
Good
learning
question.
there?
So I was very fortunate. I trained with Dr. Michael Maloro, and he's been placing zygomatic implants for 20 plus years. And I also just had a personal interest in it. So in general, at least for the way our program was structured, it was very much kind of residency is what you make it. Like there are different kind of folks out there more interested in orthognathic surgery. Some are kind of more interested in trauma surgery. I was very interested in full arch and dental implants, and he recognized that. So I was able to do a good amount of zygomatic implants. And the way that was done was I would do half, he would do half. We did some quad zygomatic implants. So I had some experience coming out
Hmm.
of residency. So I was super fortunate for that. And UIC in Chicago, excuse me, they have a PROS program too. It's like a pretty big PROS program. It's like a pretty big and well-known PROS program. So we had a lot of good collaboration with actually being able to see some of the restorative side of like, the remote anchorage. And really, actually, it's a good question because that experience was seeing these cases being restored all the way through and seeing some older cases from like generations before me. I was
Hmm.
seeing the prostheses where the zygomatic implants were placed like on the palate, the old
Transcontinental.
intrasinus
Yeah.
technique. And that was
Yep,
actually kind
through the
of
sinus.
the inspiration for like, well, how do we do this in a way that we're not just delivering a fixed denture? We're actually delivering like a hybrid prosthesis that's streamlined and doesn't negatively impact the patient's speech. So, yeah, I was super lucky at UIC. I did get some good experience there.
Yeah, that's excellent. We get a lot of students and people kind of, more and more people are knowing about full arch these days. So people D2, D3 students asking like what the best way to get good experience in this style of dentistry. So it's good to know that there are oral surgery residencies out there that are willing to allow you to place some of these remote anchorage implants. And for a lot of people, 4 years in getting that experience is a great opportunity for the ability to treat more and more patients that maybe wouldn't be able to get treated at some of these like full arch clinics popping up that they don't have the experience of placing remote anchorage style implants.
Absolutely, absolutely. Let's jump into kind of a little
Hmm.
example here. I
Yeah,
just like
absolutely.
have this slide here just kind of representing the clinical outcomes or the benefits of PATSI. So for those listening, PATSI is unique because it still is a graftless protocol, so similar to like an all-on-4. This an immediate load graftless protocol, but it has a unique advantage that we can get full arch length, right? And I would just define that as to the first molar, let's say, so a 12 tooth prosthesis, which is comparable to your more traditional style delayed full arch reconstructions, right, with sinus lifts and GBR. Wait 6 months, and then you can do six axially placed implants, and that takes a long time, but you have this beautiful arch length. So PATSI does kind of
Hmm.
check that box. And then as far as the cantilever goes, even if you don't get the pterygoids, if you follow the protocol, you will have really minimal to no cantilever, which of course from a prosthetic standpoint is optimal because we're reducing those kind of abhorrent forces on those distal cantilevers. We're reducing the number of prosthesis fractures, the amount of distal bone loss on the last implants. We all know we want to avoid the cantilever as much as possible. So the three kind of clinical takeaways with PATSI is that it's graftless, we can get full arch length, and we can avoid the cantilever. There are some other kind of non-clinical aspects to PATSI that I do like to discuss, which a few of them are standardization. So this is kind of something that I've been talking with a lot of my colleagues about where, like you mentioned, Tyler, there's folks across the world that are doing full arch and that are, employing the PATSI protocol. And if we're all going to be treating each other's, revisions and we're all going to be helping each other out for the next, 30, 40, 50 years, it would certainly help if we all kind of have the same mindset, and
Yeah.
if we were all placing our zygos, low on the zygo, right? Or if we were all trying to optimize our AP spread so that we have minimal prosthesis fractures. So standardization is kind of one aspect of this. Classification is another, so we'll kind of get into it, but there's classifications of what type of configuration that you ended up with, and that allows kind of easy communication between two full arch docs. It also helps to predict prognosis. What I mean by prognosis is how much bone is left whenever there's a revision needed. So the further along you are on the PATZI protocol, the harder it becomes to do a revision because there's just less available. So the classification is for communication, but you can also kind of get an idea for like, man, if that needs to be revised, like, very few people can do this. And I'll show you an example. And then intraoperative algorithm. So, and I'm sure you have both been there before, Tyler and Soren, where you're doing a case and, you just don't get primary stability. You just don't get torque, or it's just butter bone, right? And you're like, man, what am I going to do? And this is kind of represents an intraoperative pivot, which hopefully doesn't happen that often, but you do enough cases, you're going to get these kind of intraoperative surprises. And having a backup plan where, you feel confident that, okay, I can do this and the literature supports it, really helps. In fact, this is kind of a little aside. When I was doing the submissions and, you have to do like revisions with the reviewers of the journal, one of the reviewers commented, they said, intraoperative changes, like if you're planning your cases on a CBCT, there should be no, if you're planning it properly, there should be no intraoperative changes.
I don't reckon they do a lot of this.
You do enough cases, you're going to get this. So,
yeah.
And then the last thing, Tyler, I'll credit to you. I think you said that PATZI brings the fourth dimension to like full arch or something. So, but actually, this is really key. So it involves what I call temporal contingencies. So with the boomers getting older and retiring, there's a huge just influx of demand of dental implants and therefore full arch. And we're starting to see folks that are getting full arches earlier and earlier, which means we're going to have lots more revisions. So if we can set up our case and our geometry kind of in an ideal fashion, then the revision 20 years later will be a lot more predictable, and we can build in kind of backup plans for those future revisions.
Absolutely. Yeah. And this is something that, I feel strongly that, even people who aren't ready to do these cases, they should understand how these cases are done and understand how to leave room for the next person, should that happen. So I think it's extremely important. Yeah. I appreciate you bringing that up.
Absolutely.
Yeah. I also
want to
mention, guys, that we are playing this through video. So if you want, you should definitely tune in to our YouTube video for this portion of it. Obviously, you'll still get a ton out of the audio portion, but we are showing a protocol via slideshow at this portion. So go ahead, Sammy.
Thank you, Soren.
Yeah, I'll just kind of share one case with you to kind of kick things off. And this is a case from my residency where I was working up a case, and I got this email, I believe it was from the patient, and it was saying that, hey, I had a really bad cold or allergies or something. I sneezed really hard and my implant came out of my nose. And she sends this picture of, the first one was like an implant, and it's like tissues. And the second picture was like she's holding her implant. Like it wasn't, people will say, patients will say, oh, I think my implant came out. It might be the abutment or, it might be something else. No, this is the actual implant. So on the screen, I'm just showing the actual photo that was sent to me from this interaction, which is kind of what kicked off this case here. So what we had is this nice lady. I think she was in her 50s, actually fairly healthy. She had been in a full arch prosthesis, upper and lower, for many years, treated by a local surgeon in the area. And what had happened is one out of the 4 of her implants had failed, essentially. And you can kind of see, I'm showing a clinical photo of some really kind of boggy and kind of erythematous soft tissue around one of the anterior implants. And that's the one, that failed. And peculiarly, the two implants on the back are actually zygomatic implants, and the two in the front are traditional implants. this is what the Trupan looked like. So basically the setup was almost kind of like a Bedrosian style, two posterior zygomatic implants and then two anterior implants. However, one of them has now failed. So we can't, load the prosthesis on only 3 implants. Now, here's the thing. We talk about kind of setting yourself up for the future. I like to kind of show an example of typically what's done. And this doesn't mean that everyone has to do it this way, but, when I teach these techniques and whatnot, and I think most of my contemporaries are doing the same thing, where in general, if you're placing a zygomatic implant in the posterior region, you want the apex of the zygomatic implant to be very low on the zygoma body. And the purpose of that is to preserve that superior bone. And I'm just showing a picture here of an example of if you ever have to go back in the future and place a second zygomatic implant, or maybe even your first zygomatic implant fails, you have more bone above it. And I'm just showing an example of kind of like a standard quad zygomatic implant configuration where the 2 front implants, the apex or the apices, are engaging the superior portion of the zygoma body, and then your posterior zygoma implants are engaging the lower. So this is, I think, fairly well kind of accepted in the kind of full arch community. However, the interesting thing about this case was that the 2 implants were posterior, but the apices were placed in the superior aspect of the zygoma body.
Swords. Yeah.
And it's just kind of one of these things where, if you weren't really thinking about it and that's just kind of where you got anchorage, it doesn't really matter, right? If I'm just trying to get, torque, and that's great, but we're not just trying to get torque. We want to make sure that we're setting ourselves up in the future. So what we had to do is it makes it much more challenging for us to be able to engage any more bone on the zygoma, right? So really, and for the pictures, is a very atrophic case. The implant was actually kind of, it was beyond the piriform, really within the soft tissue of the nose, and that's why it came out through her nose. There's very little bone left. So the only bone that we really had was at the inferior border of the zygoma. So we had to do this kind of unique, kind of like almost like a crisscross pattern in order to get the anterior zygomatic implants. Now, in retrospect, I would have also placed 2 pterygoid implants on this, but we weren't doing that at that time, and that resulted in this, we call this kind of like crisscross or like X zygoma.
So
for those
now,
who are,
now you don't have the antero-superior implant. It's now like an antero-inferior implant, and vice versa. Wow. Okay.
Yeah, and this is a really hard surgery to do because we only had that little amount to get, but you're kind of angling it so far. So for those that are listening, it's basically these 2 zygomatic implants on each side are like crossing each other. It's kind of like a crisscross. So in retrospect, if this goes back to that standardization piece where if we were all kind of aligned, if all the full arch docs were kind of thinking the same kind of way, it would have made this case a lot more straightforward and kind of from a prosthetic standpoint, a lot easier to deal with.
That makes a lot of sense.
Absolutely. This is almost, we just saw the post by Holtzclaw where this is a little bit different, but he did it through the temporal fossa. And it almost would have been like if you were trying to get more posterior support here, that's probably where you would have gone in order to engage that inferior part of the zygoma without still getting that posterior spread. Is that correct?
Yeah, and that's kind of what I love about PATZI too, is because it's a really exciting time to be involved in full arch because, there's kind of new techniques coming out, it seems like every year, just with the advent of some really good kind of implant technology and just really kind of increasing the number of doctors that are doing this and kind of collaborating together and kind of coming up with different ideas. But some kind of evolution to the PATZI protocol is that it's really kind of built to be intra-alveolar things and extra-alveolar things. It's more of like a categorical based protocol. We named specific techniques in it, but for example, you could incorporate the palatal approach, for example, onto the tilted section. We didn't specifically label that one. For example, the Dr. Holtzclaw technique, Soren, that you were mentioning, the Hessian protocol, the way that in the paper PATZI is set up right now is that if you don't get the pterygoid, there's nothing else for that kind of molar option. So in cases where you really you can't get anything posterior to like a first molar, first premolar or second premolar, and let's say there was already a zygomatic implant there, or maybe a failed zygomatic implant, or sometimes you have to cut the zygomatic implant. So what he did is he angles it very far posteriorly so that the platform is coming out almost like where a pterygoid is. Mm-hmm. And he dissects the infratemporal fossa, and he comes up medially through the infratemporal fossa and pops out anterior to the zygoma, and he's able to get a zygomatic implant that's kind of pitched fairly posteriorly. So these kinds of techniques are just continuously evolving in remote anchorage, and the PATZI protocol, you could certainly add these techniques kind of as needed basis.
Yeah. And I think it's so important too, because, with a technique like that specifically, that, its emergence is going to be very similar, like you said, to a pterygoid. So if you miss a pterygoid, that might be an option. But now you're also using that zygomatic real estate, and you also need to consider, well, what do I have up front? Am I going to need other spots in this zygoma for other points of anchorage further anterior? And so if you're not thinking about this algorithmically, you may end up kind of sacrificing some real estate that you're going to end up needing later on in the case. And so I just love how there's this stepwise function as you're working through the case to establish that anterior posterior spread. And especially, like you were alluding to earlier, Dr. Samy, you have to be thinking about, if you yourself have to revise this, what you're going to have to work with, and if someone else is going to have to do it, making sure that you're following along with this so that you're leaving room, even if that's not within your clinical suite. You need to make sure that there's still going to be more interventions possible later on. And I think it's just brilliant. It's providing a framework for new innovations to come in. So I love that.
Absolutely. I think what we can do is perhaps we can kind of break down each category and kind of go through it, because especially for the folks that are listening, is probably kind of confusing. So let's just jump into the actual kind of algorithm here. So I just included this just to kind of give some ode to Bedrosian, who really kind of came up, I think, with the original kind of first algorithm, so to speak, for full arch, which is talking about zones 1, 2, and 3, or zones of bones. Where zone 1 is, of course, the anterior maxilla, zone 2 is the premolar area, zone 3 is the molar area. I've seen some kind of adaptations of this where you could call zone 4 the zygoma and zone 5 the pterygomaxillary complex. So how do we incorporate those on top of this? So this is kind of the photo, or the kind of figure that we showed, where for those that are listening, it's basically kind of like a stepwise, like down arrow for each section: posterior, anterior, tilted, and then zygomatic implant. And it's done in that order. So posterior, this would be referring to a pterygoid implant. Some of the kind of editors or commenters on the publication were suggesting, well, you could get like a first molar, an axial, you could, but the thing is, if they're getting full arch, it's very rare that you do have alveolar bone to do something traditional like that. And the three of us actually are not the biggest fans of those kind of like short implants, at least personally, kind of in the posterior maxilla with that really kind of buttery bone. Yeah. I do prefer getting something a little bit longer that's kind of engaging cortical bone. So what we decided to do here is just say, okay, pterygoid implants. Go ahead and attempt to place your pterygoid implants. Let's say we get both pterygoid implants. Okay, great. Now we're going to move on to the next section in the algorithm. If we don't get pterygoid implants, we're going to consider this null, meaning we didn't get any pterygoid implants. So we'll move on. Now we're jumping to the anterior section. And this is kind of where you'll start to pick up the pattern that it's categorical. So each section from here, it's like you have one section which is like traditional implants, and then you're going to have an extra alveolar section. So let's say we go to the front, we got our pterygoids, we're going to place some anterior implants. And we show kind of many examples where you can do kind of piriform rim, engage in piriform rim implants. You can kind of do an overlap where one is kind of towards the anterior nasal spine, one's towards the nasal crest. You can do lateral nasal wall implants towards the lateral nasal wall. In very challenging cases, you can do a nasal palatine foramen, but we need some kind of anterior anchorage. Now here's kind of where the algorithm kind of comes into play, where let's say we don't get any anterior implants, traditional. In this case, we have the option of going to the extraalveolar option in the anterior, which is a transnasal implant. And this is also somewhat of a newer technique. We won't jump into specifics, but basically it engages the what we call the Z point, or basically that bone where the inferior turbinate joins the maxillary process. But it's cortical anchorage, and by doing this, you can actually avoid that anterior zygomatic implant, which would be the next backup plan. So if we couldn't place any anterior implants, we would assign this section as null, and we would continue to move on. So then we get to our tilted section, where in the intraalveolar section, we're placing 2 regular tilted implants anterior to the maxillary sinus. If we can't get that intraalveolar option, which, by the way, you could add certainly, you could add the palatal approach kind of within this section too.
Sure.
If you couldn't get a regular intraalveolar option, you would then move to more of a transsinus approach, which is essentially elevating the anterior aspect of the maxillary sinus membrane, traversing your drill through that anterior maxillary sinus, and then engaging the lateral nasal wall. So you can actually get your platform pretty far back with these, but it just depends on the thickness of your lateral nasal wall. It's got to be thick enough to get anchorage there. If we can't get that.
At the risk of going too tangentially, do you always elevate the membrane when you do your transsinus, or have you ever just blown through it?
I do. Yeah, I
Okay.
personally do. I know some folks don't. When I was first trained in zygomas, we were doing that. We were just kind of going right through, and I saw a lot of complications with that. So whenever, even with zygos, with everything, I very much respect the maxillary sinus membrane.
Very nice. Got it.
Let's say, okay, we didn't get anything in this section. We'll call it null. Here is kind of where the kind of algorithmic side of things pops in. So what I'm showing here is a zygomatic implant section. So essentially there's 3 subsections within the zygoma section. If we're unable to get a tilted implant, it directs you to placing a zygomatic implant, but there's 3 styles of zygomatic implant. In the tilted section, meaning premolar section, we do what's called a Z1 zygomatic implant. Z1 means that the platform is coming out the premolar area, and the apex is low on the zygo, basically. The next section is, let's say you couldn't get a pterygoid implant, and your tilted implants are really far anterior, so you're going to have that short arch length. Or we're going to want something back there, right? And that's where we're going to do, it's called a Z2 zygomatic implant. So we get basically a platform of the zygomatic implant at the molar region, and the apex is low on the zygo. So the chart basically tells you, hey, where's your implant position, implant platform position? Where's the apex position? It's very kind of specific. And then if on the anterior section, if you couldn't get any anterior implants, maybe the patient's not a candidate for transnasal implants, that's when you actually place that anterior zygomatic implant with the platform in the anterior region, perhaps the lateral incisor or the canine, and then engaging the superior aspect of the zygoma. So this is really the only publication that we know of that specifies where is your apex going to go, because it highly depends on the anatomy of the zygoma body. So in this way, any section that we were not able to get, you make up for it in the zygomatic implant section. So what we can do is, how about we just kind of go through a couple of like quick examples, and it might be able to kind of help visualize. Does that sound okay?
Sure, please.
Yeah, absolutely. I have a quick question. I'm learning a lot from this, so I really appreciate it.
Me too.
So in the anterior region, in your opinion, if the patient is a candidate for a transsinus approach, or I'm sorry, a transnasal approach, you would place that transnasal implant over doing something like a quad zygoma to keep that zygomatic bone for a future issue,
Correct.
potentially.
Mm-hmm. Correct.
Okay.
Yeah, I personally would, but the thing is that you need at least 3 millimeters of kind of
Yeah.
alveolar bone before getting to the inferior, the piriform rim there, because just risk of oral nasal fistula. So
Yeah.
if it's too thin there, or a lot of times they won't even have enough
The
bone
concha's
there,
not there.
like at the
Yeah.
Z point. Yeah. So
Mm-hmm.
sometimes they just,
Mm-hmm.
you can't, and then you're basically doing a quad. But the idea is like, hey, how can we avoid doing a quad, as much as
Yeah.
possible? Because after that, that's really it. I mean, there's subperiosteal, custom subperiosteal, but essentially we always try to avoid doing a quad. Pull up a couple of these cases here. Okay, so here's kind of an example of a PFAS, or fast, right? But a little trivia here is a PFAS is the same as a P1, A1, T1, Z0. So these are pretty common cases that I do where I really don't need any zygomatic implants. But to kind of walk through the PATZI algorithm, this is showing a case where we started in the posterior, we got both pterygoid implants bilaterally. Then we moved to the anterior. We got 2 piriform rim implants anteriorly, good torque. Now we're going to move to the tilted section, and we've got a nice, good position of tilted implants with good torque. We've got 6 implants, all good torque, immediate load, no issues. No zygomatic implant is needed. And this is where the numbers kind of come into play, where the lower the numbers in general, the more real estate there is to play with in the future.
Yeah.
So if this patient comes back in 30 years and let's say that the right tilted implant fails, well, you have an option. You could leave the span from those 2 implants, or I could place a zygomatic implant here at the inferior portion and really kind of preserve that nice even spread that's kind of ideal from a prosthetic standpoint. Here's kind of the next iteration here. This is an example of, let's say we don't get pterygoid implants. Mm-hmm. And in the unique scenario where maxillary sinuses are super anterior, I mean, they're just so pneumatized. So let's say, okay, we start in the back, couldn't get pterygoid implants, right? And we've all been there, no torque, there's no stability, butterbone, whatever it is, can't do it. Now we go to the anterior, place 2 anterior implants. This case is actually a Dr. Juan Gonzalez case. 2 anterior implants, great. Now let's go to our tilted. Now although we have bone for tilted, if you look really closely, he was basically hugging that anterior maxillary sinus. It was very pneumatized. So going as far back as you possibly can, the picture basically shows that probably you'd end up, if lateral nasal wall is around the canine, probably you'd end up around first premolar to the most posterior extent if you were done here, right? But we want to get a little bit more anchorage so that we don't have a 2-tooth or more cantilever. So in this case, zygomatic implant was placed, but it was specifically the Z2 zygomatic implant because the posterior section was null. And what does that mean? That means you place the zygomatic implant in the molar area and the apex at the inferior aspect of the zygoma.
Yes.
Here's kind of where we start to get a little bit more kind of into the remote anchorage. Where honestly, these cases just wouldn't be possible, 15 years ago without some of these techniques. So this is a case where, okay, we start in the posterior, we get pterygoid implants, get both sides, perfect. Let's move to the anterior. This panoramic is very severe atrophy in the anterior. Unable to get any traditional anterior implants, so transnasal implants were opted and were successfully anchored. And now in this case is actually even more pneumatized than the previous one. So very atrophic alveolar ridge, severe pneumatization of the maxillary sinuses. So the zygomatic implants are placed here in the premolar region, which the algorithm will tell you platform in the premolar, apex low on the zygo. And this is strategic, just in case one of the transnasals fails or maybe one of the zygos fails, we're still preserving that superior zygoma bone for the future if we need to put another one in.
So in other words, you've got your furthest posterior extent as far back as it could ever be, pretty as far as anterior as we're ever going to be, and we're trying to bridge that gap somehow, and we're using sort of the most conservative zygomatic implant we could, which is very inferior, and we're just trying to get something between those uprights.
Exactly.
Okay.
And
Got it.
you can imagine the span, if you didn't have those middle implants, pretty much kind of from lateral incisors all the way to kind of second molars. If you were really truly just doing four,
And
which,
this is
depending on the
something
bite force.
Yeah, and this is something I'm curious about too. So there's a very significant population of full arch docs now who have not bridged into zygos, who are competent with pterygoids, but sometimes in that sort of tilted region, it might be kind of hit or miss. How far do we have something in the literature sort of guiding us as far as, how long that span can be without creating that sort of, moment there that where things can flex and break?
Yeah, it's a good
I was going
question.
to ask the same question.
Yeah.
So in some of Dr. Holtzclaw's lectures, he's showing some cases and some literature reviews where essentially like the middle implant has failed, and that now you have a span, from like canine or lateral incisor all the way to the pterygoid. And essentially those cases are still in function.
Yeah.
Personally, I'm just not the most comfortable with it. I typically don't like to have a
Yeah.
span of really more than like 3 teeth, even like 2.5 teeth without having an implant. I mean, nowadays, especially post-COVID, the amount of bruxism and bite force, the amount of just heavy grinding that we see, I always just try to brace my cases as much as possible, because it also makes, my restorative colleagues happier, because like less, fractured prostheses, especially with zirconia nowadays. So the literature says that you can have a span that long, essentially, but I wouldn't bank on it.
Yeah, I mean, I think it's one of those things where we may not know exactly what our tolerances are. It's not like the whole AP spread thing where, we have very like specific instruction on what can be tolerated for, a cantilever, but it's intuitive, like if it's that long of a span, there's going to be flexure there. Our materials, especially zirconia, is not going to tolerate a very long span for very long, right? You need something to kind of fixate and sort of, bridge that gap. I think it's just an intuitive thing. It makes sense.
Yeah.
These,
And the other thing too. Oh, go ahead, Soren.
I just had a quick question about transnasal. I feel like and I know they have been around for a long time, but I feel like they might be more recently. People are starting to talk about them more, the transnasal, and always the first thing people talk about are the issues that can arise with these implants, right? When Zygos first came out, there was a lot of people hesitant about them because of all these issues, and it's kind of become more popular now. And I feel like nasals are kind of in that beginning category where some people are nervous to place them. My understanding is one of the biggest complications that can arise is damaging that lacrimal duct and causing, like excessive, crying or like tears, and then having to send the patient to an ENT to then repair that duct. And I know it is repairable, but is that kind of the main complication you've seen? Has it happened to you before? How have you managed that? Those are kind of my main questions.
Yeah, and Soren, you cut out for just 1 second, but I think I heard basically like what's like your main concern with transnasal implants, right?
Yeah, correct.
Okay. So the main one is essentially there's the nasal lacrimal duct is quite close. So there's basically there's like three possibilities in general of like what they could look like with how far that kind of Z point bone is from the nasal lacrimal duct. And it just anatomically, some folks have it where there's really not much bone there. And it's those cases where if you're angling the apex of your transnasal implant a little bit too far posteriorly, you can actually damage the nasal lacrimal duct. So the problem with that is what you can get epiphora, where basically the nasal lacrimal duct, what it does is it drains the tears from the eyes essentially down through the nasal system. So if that's happening, if the nasal lacrimal duct is blocked, what will happen is the patient will just have constant kind of tearing, like overwhelmingly. And there's a procedure, typically it's done by, these are usually done by oculoplastic surgeons or perhaps ophthalmologists, but at least the ones I've seen were oculoplastic surgeons, where they basically have to kind of move the connection to drain to a different spot. And it's called the DCR, dacrorhinocystostomy, where we had to do like stuff like that with reconstruction, like maxillectomies and stuff for different reasons. But that's, we'd like to avoid that. So we should probably also say, just for everybody, like these remote anchorage cases, you got to get training. These aren't really things that you just kind of want to jump into. Pterygoids, zygomatic implants, transnasal implants, like the cases that, we're showing, these are all done by, heavily experienced docs. So, and there's lots of opportunities to learn, but I don't want this to come off as like we're underplaying the complexity of these, because, you got to get training and there's a lot of complications. But yeah, that's the main one. And the other one is oral nasal fistula, because an oral nasal fistula is a whole lot harder to repair than an oral antral fistula.
Yeah, and I think you mentioned your guideline on that is having at least 3 millimeters of like subantral or subnasal bone there. So and
that I believe that's from the Vanderlim paper.
Okay.
Camargo Vanderlim, he was really the kind of the OG who described it. To my knowledge, there's really only 3 or 4 papers on this. David Zelig, Simon O have one. I mean, there's only, you could name it on how many docs are, on one hand, how many publications are out there. So This is very new. However, it's becoming popular because of how much remote anchorage has become. It's just, the demand is out there now. That's kind of why we're seeing so much more of this now.
Right.
Let's do, I think I have one more here.
Mm-hmm. Yeah, absolutely.
Okay, yeah, this is kind of, of course, the most severe here, the most severe atrophy. So what the screen is showing is essentially a quad zygoma configuration. But the point here is that, the surgeon has given an honest try, or at least has really considered all of the options to try to avoid to getting to this. So in the posterior, they were actually able to get both of the pterygoid implants. In the anterior, there's really not enough bone for traditional implants, not enough bone for transnasal implants, or for some reason just contraindicated. So an anterior zygomatic implant was placed. And then in the in the tilted region, not enough bone for regular tilted implants, very kind of thin lateral nasal walls. You can't really do a trans sinus implant. So a posterior zygomatic implant was placed. So what you're seeing is basically a quad zygomatic implant with pterygoids. Mm-hmm. And this is kind of the end point, really, of PATZI, without going to something like having to, if this fails, there are docs there's a few docs who can handle that, like revising these cases. Usually these quads, you got to cut the implant, you got to find, but it's very challenging. But if you had to truly do a complete revision, there's very little options, and that's when we'd be talking about something like a custom subperiosteal implant, or a removable, like a removable denture.
So I'm curious about something too. So there's this, if for those of you who aren't seeing it, all these examples and what's below it have this really brilliant, sort of way of codifying all of these cases. So we have the PATZ, and then you have the subnumeral there with the 1 and the X that corresponds to this really awesome graphic that we have. But I've noticed that on all these examples, they've been symmetrical. I'm curious, have you guys figured out a notation for left side look like this, right side look like that?
Good question. Yeah, great question. For the purposes of like simplicity for the paper, we kept them all symmetrical, but the reality is, you've probably seen some of my cases, it'll be a unizygo, or it really kind of just depends on what the case needed. So what I like to do in those cases is I'll just put like R and then the whole thing, and then left L and then the whole thing. Cool. It just this is still kind of new, so like people people don't even know what I'm talking about, so I don't really do that. There's a doc who does it a lot, Dr. Tyler Rushing, great surgeon here in Austin. Yeah, he like will always like number his PATZI, and I just love to see it. And
Yeah.
then Dr. Tomasz Krasinski in
Uh-huh.
Poland, he also
Uh-huh.
just beautiful cases. He
Yeah.
also does it too. But
Cool.
I'm sure a lot of the audience of their followers are like, "What is this like numbers?" So, I tend not to show too much of it. But yeah, easiest way would be like right and then left if it is an
Okay.
asymmetrical case.
Yeah. I mean, I think it's just
So
so
we've been
smart
talking a lot
because,
about.
yeah, I was
Sorry.
just going to say, Soren,
Okay. I
Anything like that, we were kind of like shied away from because of the repair that would sometimes have to go into that. But I did do several of them kind of for a different indication, like for like an ameloblastoma resection. If that tumor is involving a portion of the nerve that needs to get resected.
yeah, well, like, we go on Instagram and we see all these, post-op CBCTs with crazy implant configurations, zygos, transnasals, all these things. And it's like, we can share the pictures and we're like, oh, wow, check out this case, check out what they did here. But we haven't up to this point, like, had a way of actually classifying what was done to where you could just look at this algorithm and have an idea of what that case actually looks like. That's why I think this is just absolutely brilliant. It's really cool.
Yeah, and it just
Yeah, I
kind of
agree.
helps. I mean, the world is becoming healthcare is becoming a very kind of global phenomenon, right? Where I mean, we're
Yeah.
seeing people who have been treated in different countries for full arch. People from the U.S. that have been treated for full arch are going to other places for revision. So
You bet.
there's
Yeah.
just kind of like a mix matching, and that causes, of course, a lot of issues with compatibility, difference in philosophy, just difference in techniques. I mean, there's so much variability that goes into just healthcare in general, let alone full arch implantology. So this is kind of at least our best effort to try to at least standardize the way of doing these particular cases,
Yeah.
which are usually the most challenging because that way, if I see a case and I need to send it to Dr. Zelig in New York, we can kind of speak the same language. I can
Right.
say, hey, this is what I did.
Mhm.
I think there should be bone up here. Like, look at the scan there, and that's kind of how we can
I
communicate
love it.
with each other. Versus that first case I showed, with the bone that was occupied there, you know, I wasn't able to. I should have been able to use that bone, right, to put a zygoma implant, but it made the case much more challenging
Yeah.
and difficult to restore.
I really appreciate these cases you've shown. They look excellent, and I think, like you said, getting to the point where we all can utilize a similar system to do these more advanced cases, I think will help everyone um, in any country or any region. A question I have for you is, as far as a lot of these approaches are maxillary, right? And we do have limited options. For the mandibular cases because we have the IAN running through there, the mental nerve, and I feel like for the we have the traditional all in four, and then obviously if you can place six, you can do that. And then the going beyond that is subperiosteal style implants. Um, a question I have is, when we have these cases where patients have really soft bone, and we do see that pretty often in the mandible, with
Yeah.
the wide hollow mandibles where you place your spade drill and you're kind of just pushing it through that region. I'm seeing more people, like Juan Gonzalez and a couple other surgeons who are starting to place some of these really long implants in the mandibular region to engage the inferior region of the mandibular bone, in order to load these cases instead of delaying those cases. And I always, my thought is and I'm curious what your opinion is. Do you find that for a patient like that, it makes more sense to place maybe like a 20 millimeter implant in the mandible in order to engage that inferior cortical bone, or doing something like a delayed load protocol, and then maybe saving some of that bone for future use? My biggest concern with
Hmm.
it is let's say the implant does fail and all of a sudden you're removing a 20 millimeter implant in the mandible. That's going to do a lot of damage because of how thin that mandible is versus, a lot of times the maxillary bone is a little more forgiving in that aspect.
And that's a great question because what you're doing, Soren, is you're basically adopting that mentality of like, how do we plan for the future? How do we optimize this patient so they're going to be in the best hands for the surgeon who treats it 30 years later, which is really kind of what PATZI's about. So that's awesome that you're thinking that way. And I think it's a matter of philosophy, because this will come down to doctor preference for sure. So I think a lot of the cases that you're seeing, Juan Gonzalez, Dan Holtzclaw, those docs, like basically it's a zero, like it's 100% immediate load. Like they're not going to want to do a delayed protocol just because of not wanting to have to put the patient to sleep twice, or not having like a recovery and just kind of patient satisfaction. So I think it comes down to weighing your risks and benefits. If it's super atrophic and you're running the risk of like fracturing the mandible or something like that, then, I mean, so what if you get immediate load? Who cares if the mandible is fractured, right? Just do a delayed load. So, but basically for like remote anchorage for the mandible, you really only have the inferior border. I've seen folks put a pterygoid implant, in the tilted section to get all the way down to the inferior border, because they just couldn't get torque, and that's the tough thing. The only other thing really when it comes to these revisions, the only other technique that I can really point to is basically nerve transposition or nerve lateralization, which it's. I mean, I think in the right hands, sure. I mean, I did some of those more for like reconstructive purposes, like resections and stuff. But there's a lot of, there can be some morbidity associated with that, with delayed kind of paresthesias and stuff like that. So I think in the right hands, it's a great option to really just kind of be able to use like a posterior implant where you can actually engage the inferior border without having to worry about that nerve. So that's the only technique I can think of, and it's not really a widely practiced. I know some folks that are doing it very well, but it's less common.
Are you doing any of those nerve lateralizations commonly in your practice?
I'm not. In my residency, we did a lot of nerve grafting. So we were kind of like Dr. Malora is kind of like one of the leading experts on nerve repair. So we got a lot of referrals, from across the U.S. For nerve injuries, from implant placement, from wisdom teeth, orthognathic surgery, and we go in there and have to kind of resect a little neuroma and then hook it up and graft the nerve. So some of these procedures that would have like a slightly higher paresthesia rate, or you can kind of chart a path, create like a new kind of mental foramen, pull the healthy part of the nerve out, graft it, or rather, anastomose it proximally, and then you can take the distal end of the graft and you can insert that into the soft tissue stump. This is kind of like reconstruction type of stuff, but it's the same. It's really like the same concept with a dental implant. You're putting a dental implant there instead of just removing the bone.
Hey everyone, thanks for taking a second to listen to the episode with Dr. Samy. Make sure to tune in for a follow-up episode where we discuss some of the really difficult cases he has and how he manages those. Also take a look at JB Dental Lab. We use them for all of our fixed arch treatment, and they have some really good analog and digital protocols for any workflows that you have in your office. Thanks again.